Assalamu alaikum. This presentation is on bilateral vocal fold paralysis. This is a rare but serious condition of reduced or even absent mobility of both vocal folds. This may lead to a very narrowed glottic airway that can sometimes be life-threatening and requires urgent intervention. The cause for this serious condition is usually neurogenic paralysis of the recurrent laryngeal nerves, or combined sometimes with the superior laryngeal nerves as well in high vagal paralysis. But sometimes it can be caused by the immobility of the vocal folds due to mechanical fixation of the cricoarytenoid joint. The distinction between vocal fold paralysis and vocal fold immobility is important in the diagnosis and the management. How common is bilateral vocal fold palsy? It comes as the second most common cause for laryngotracheal stenosis. The number one cause, of course, is acquired laryngotracheal stenosis, which accounts for about 50% of the cases. The bilateral vocal fold palsy accounts for about 16% of the cases in adults. It's also the second most common congenital laryngeal abnormalities in pediatrics, accounting for anything between 10 and 20% of all pediatric laryngeal conditions. These are the major causes for the bilateral vocal fold palsy, starting with the neurogenic causes, particularly inflicted during surgery for thyroid and parathyroid or mediastinal interventions, or trauma to the neck and the larynx or the skull base, or tumors of the thyroid and other parts of the neck or the mediastinum. And also idiopathic causes make a big chunk of the main categories for bilateral vocal fold palsy. Other causes including certain infectious diseases or metabolic disorders and some pediatric specific or congenital abnormalities, and also you'd have to take into account the mechanical fixation of the cricoarytenoid joints. Some more details on the neurogenic causes that include surgical trauma, particularly thyroid, which accounts for about 60% of the causes, but other neurological diseases, including Arnold Chiari syndrome and amyotrophic lateral sclerosis or brainstem tumors or even stroke, and neuromuscular conditions like myasthenia gravis, for example, or post-polio, or peripheral nerve conditions like Guillain-Barré or trauma to the recurrent laryngeal nerves or tumor compression of the nerves. The iatrogenic causes, again, are basically formed of the thyroid and parathyroid surgery. This is by far the most common in adults, but other neck procedures and mediastinal or esophageal surgeries are also prominent, including endotracheal intubation inflicted by compression of the tube itself or the cuff, and other neck surgery, including external carotid endarterectomy. Other groups of causes for bilateral vocal fold palsy include head and neck trauma, strangulation, caustic ingestion, infectious diseases including TB or syphilis, Lyme disease or viral neuritis, metabolic syndromes including hypocalcemia, hypothyroidism or heavy metal poisoning or overdoses with vincristine, or neoplasia, particularly those of the thyroid, the lung, the esophagus, the mediastinum or the skull base, and lymphadenopathy in the neck or the mediastinum. Mechanical fixation is a different condition but has to be excluded at the very beginning. Mechanical fixation can be caused by posterior glottic stenosis due to intubation or caustic injury, or cricoarytenoid joint ankylosis or dislocation from trauma or arthritis or radiotherapy. And this condition should be differentiated by direct examination, including examination under anesthesia and trying to mobilize the arytenoids, and CT scans find cuts for the cricoarytenoid joint, and certain other investigations, including EMG, because this condition may be correctable surgically. The classic triad for clinical presentation is an airway compromise, voice changes, and swallowing difficulties. Mostly the vocal folds will be lying close to the midline in the median or the paramedian position, leaving about a small glottic chink, and this would reduce the airway and cause the airway compromise, but would favor voice production and also swallowing. In cases of high vagal paralysis or injury in the skull base, for example, the vocal folds position will be a little bit more lateral. This will give a better airway, but on the expense of a weaker voice and more chances for swallowing disturbance, particularly aspiration if the internal branches of the superior laryngeal nerves are affected. The airway compromise is of primary concern, of course. This would cause inspiratory stridor, dyspnea on exertion, or even sometimes respiratory distress at rest. The voice changes, which is usually acceptable initially if the vocal folds are in the paramedian position, but there will still be an element of breathiness, and the voice would be weak with a reduced intensity and a reduced pitch range. It would decline if there is a high vagal paralysis with drifting of the vocal folds laterally and become more breathy and with a rough quality. The swallowing disturbance and the aspiration can also cause coughing and recurrent pneumonia, particularly in children. They would have silent aspiration and recurrent chest infections. The diagnostic approach would start with a clinical evaluation in the outpatient clinic with history, taking and physical examination of the head and neck and the cranial nerves. A flexible fiber-optic examination is the starting point, but direct examination under anesthesia may sometimes be necessary to differentiate cricoarytenoid fixation from paralysis. Imaging, the CT scan from the skull base to the mediastinum in search for a cause for the paralysis, and sometimes MRI scans if a central cause is suspected. Fine cuts laryngeal CT scan may be necessary to evaluate the cricoarytenoid joint in cases of suspected cricoarytenoid joint ankylosis or displacement. EMG is sometimes of importance to distinguish neurogenic causes versus fixation, but also it will help in predicting the recovery of neurogenic causes and timing of permanent procedures. And some other tests, including laboratory tests. For example, these laboratory tests will be in search for a possible cause for the disorder, including electrolytes and thyroid function tests, serology for autoimmune or infectious suspected etiologies, and pulmonary function tests. Will come to this in a second, and also sometimes certain tests for swallowing disorders, including FEES or video fluoroscopy may be required. Pulmonary flow volume loops will show a reduced inspiration flow. The expiration may be normal if there is variable obstruction due to partial paralysis, or it can be also reduced if the paralysis has the vocal folds fixed in position. The common thing will be a reduced air entry during inspiration and sometimes some variability in the flow of air during expiration. And then the treatment options. The main goals of the management for bilateral vocal fold palsy is to restore an adequate airway with or without a tracheostomy tube. This is of prime importance, an adequate airway. Also, you would need to consider ways of optimizing the voice and the swallowing functions, and to preserve as much as possible the laryngeal anatomy by any procedure. The treatment choice is of course governed by the cause for the paralysis, the degree of the severity, whether recovery is expected or not, and whether the patient has any other comorbidities, and the available resources, whether laser or other techniques. A presentation with an acute airway compromise is a medical emergency and has to be attended to immediately. Usually the initial management would be a tracheostomy or an endotracheal intubation. This is particularly seen in post-surgical cases where immediate recovery is unlikely. In the acute phase, the airway compromise should be sorted either by a tracheostomy, or if the airway is fairly stable, you may afford to watch and see. If a tracheostomy is done, this would give an immediate effective airway, but it has its psychosocial and long-term care issues. The decannulation rate is about 77%, particularly in children. After sorting out the problem of the compromised airway, depending on whether the cause of the vocal fold palsy is reversible or the prospects of regaining the mobility, you can afford to observe the patient for 6 to 12 months in adults or up to 1 year in children for signs of recovery. During that period, you could help with voice and swallow therapy. This would be basically a compensatory strategies, particularly to avoid the complications of things like aspiration and help with better voice projection. Medical therapy has a very limited role, mainly supportive. Sometimes steroids can be useful in the early acute phase if the condition is reversible. Anti-reflux agents are also helpful in reducing the inflammation of the larynx that may add up to the airway compromise. For definitive therapy, this is an outline of the endoscopic surgical procedures that ranges from a posterior cordotomy, usually done by laser, to partial or total arytenoidectomy, again mostly by laser, or a suture lateralization that can be done in the immediate post-operative period after thyroidectomy, for example, and scar lysis or microflap repair in posterior glottic stenosis. They are effective usually in widening the airway. The rate would vary a little between one and the other. The maximum airway patency would be achieved by a total arytenoidectomy, but then on the expense of the voice and the swallowing. All these procedures could affect the voice because the airway would be widened and also would risk swallowing difficulties or aspiration. As much as the total arytenoidectomy gives the highest possible airway patency, it also risks aspiration and have effect on the voice. Its effect on the voice is severe, but this effect on the voice and the swallowing is across the board with various degrees. It's usually milder with suture lateralization. Decannulation rate is again high in most of them, very comparable, ranges between 80 something and high 90s. The posterior cordotomy is usually the preferred first or initial endoscopic option. The suture lateralization has the advantage of being reversible. The other four options are not. There are other adjuncts and experimental therapies, including Botox injection, which is mainly used in selected cases with some regeneration of the nerve with synkinesis, and it can help in refining the output. And it is reversible, of course. Selective reinnervation of the larynx is also being used, but only in small series of patients with variable results between 50 and 100% success rates, but it is technically demanding. Laryngeal electric pacing is being increasingly tried It has the potential for a dynamic restoration of the airway rather than a fixed position. But again, clinical trials are ongoing, but it's not an established line yet. The same applies to gene or stem cell therapy, still in the experimental stage, although it has a future potential for neural regeneration. The suture lateralization by adjustable vocal fold latero-fixation is a reversible and a non-destructive technique that can be used in the immediate post-operative period after a thyroidectomy, for example, if bilateral vocal fold paralysis was noted. It entails passing of two trocars from the neck. Surface landmark of the vocal fold would be determined, and one trocar would be passed under the vocal fold and the other through the ventricle above the vocal fold. Through these trocars, you would pass a needle with an attached suture, which will be retrieved from one trocar and passed into the other, so that you would have the suture line around the posterior part of the glottis, and it would be tied in the neck. You can adjust it to effect a measured amount of lateralization of the vocal fold. It's a straightforward procedure and it's non-destructive. It's favored as in the children and when spontaneous recovery is expected, because you can always cut the suture line from outside if the vocal fold starts to move again. Aspiration initially is a small risk, but it soon gets better with patient taking voice and swallowing exercises. The other group of procedures for widening of the narrowed glottic airway is the laser microlaryngosurgery, which entails balancing a widened airway with the preservation of voice and swallowing functions. It's usually by doing a posterior cut in one of the vocal folds, although it can be done bilaterally, and it's widely used particularly in pediatric cases. There is a high reported decannulation rate after a widening of the airway, up 97% or so. There will be some voice weakening, but the impact is usually mild. But when there is no potential for recovery of the bilateral vocal fold paralysis, surgical intervention in various forms would be indicated to clear the airway obstruction. One of these ways is the Denis Kashima cordotomy operations, various types, using carbon dioxide laser. The procedures depends on making an incision in the vocal folds to clear posterior airway narrowing, together with a part of the arytenoid, either the vocal process or even part of the arytenoid body itself, with various extension anteriorly and laterally according to the degree of the severity of the obstruction. You can do it unilaterally or you can do it on the two sides. In the simplest form, in the type 1 Denis Kashima cordotomy, the vocal process of the arytenoid would be ablated together with an adjoining part of the posterior part of the vocal fold and the posterior third of the vocal fold. In grade 2, this is the posterior vertical cordotomy. The cordotomy would be extended up to the half of the vocal fold anteriorly, rather than just cutting and transversely in type 1. In type 3, this is the extended cordotomy. Part of the arytenoid would be ablated together with its vocal process, and the vocal fold would be transversed extension all the way up to the inner perichondrium of the thyroid cartilage to allow for a clearer airway, and it can be done bilaterally. In type 1 Denis Kashima cordotomies, the airway obstruction is mild, and here you can afford to have a small cordotomy in order to preserve a good voice, because the airway obstruction is mild. But when there is a moderate airway obstruction and compromise, here you would need to have a bigger incision, and that incision could extend anteriorly into half of the vocal fold. This would obviously affect the voice, but there would be some more improvement in the airway. So a balance between preserving the voice function and clearing the airway, very critical balance, would have to be determined between the surgeon and the patient. In the type 3, this would be used in severely compromised airway, or if the previous surgery for type 1 or type 2 had failed. Usually it's the extended cordotomy plus the partial arytenoidectomy, and this will give a poorer voice but a better airway. The cordotomy is carried out with carbon dioxide laser in a super pulse or ultra pulse mode. You use the suction in order to retract the arytenoid away from the field, and then use the laser to cut transversely into the vocal fold, including the muscle fibers of the thyroarytenoides. And this cut would now be extended all the way to the inner perichondrium in type 3. It would stop at this level in type 1 together with the vocal process of the arytenoid. But here you can see it extended all the way up to the inner perichondrium, and then you also extended vertically a little bit like an L-shaped incision, and this is going to cause curling of the fibers of the thyroarytenoid muscle, forming the bulk of the vocal fold, and this will clear the airway. Here we are deepening the cordotomy through the muscle fibers, and you would see an extension, a vertical, obliquely vertical extension into this area as well, and this is going to help in the curling of the fibers. And part of the arytenoid would also be ablated together with its vocal process, and this would give a fairly satisfactory posterior airway just by doing it on one side. Of course, you can do it bilaterally, but then this would increase the risk of aspiration. The settings for the carbon dioxide laser in the super pulse or the ultra pulse mode would be power between 2 and 5 watts, and the power on would be about 0.2 to 0.4 seconds, and typically we do it only unilaterally first to see if this would be enough for the patient to have his tracheostomy tube removed. But if not, you can always do the other side as well. In addition to the carbon dioxide ultra pulse use with the usual settings, the KTP fibers can also be used in a power between 6 and 8 watts as a pulsed mode to ablate the tissues much in the same way. And one big series had suggested that the results of the KTP is very similar to the carbon dioxide laser, but the carbon dioxide is still more common for cutting the cartilage, and thulium is rarely used in this type of operations. If posterior cordotomy alone fails to provide adequate airway, then the next operation to consider would be removing of a part or even the whole of the arytenoid cartilage. Usually a partial arytenoidectomy would be sufficient to clear enough airway for breathing and achieve decannulation from a tracheostomy. But sometimes total arytenoidectomy, particularly in misplaced arytenoids or ankylosed arytenoids, should be tried. In that case, it's very important to keep at least the posterior shelf of the arytenoid covered by its intact mucosa, hypopharyngeal mucosa, because that would help in reducing the aspiration. The total arytenoidectomy achieves a quite high decannulation rate, up to 98%, but equally good, it affects voice and swallowing more, and the voice would be very weak and breathy, and there is a risk of aspiration. The cordotomy operation can be used in other conditions, including bilateral cricoarytenoid joint fixation due to trauma or due to rheumatoid arthritis. Can also be used with interarytenoid adhesions, posterior glottic adhesions, following, for example, endotracheal intubation. The cordotomy procedure would create enough airway, particularly if it is done bilaterally. Most of the airflow would be in the basal half of the glottic area. More than 75% of the flow would be in here, and with bilateral cordotomies the airflow would be adequate, and in most situations even unilateral cordotomy can give an adequate airway, allowing for removal of a tracheostomy tube. The problem, of course, is that this comes at an expense of the voice will be affected, becomes breathy, although it remains functional. The other dreaded complication is aspiration, and this should be taken into account when decisions for this type of operation is taken. This operation, microlaryngeal posterior cricoid split, can be used for airway compromise after denervation or after cricoarytenoid joint fixation. The posterior cricoid plate is splitted using laser, and then the space is created between the two cut ends by placing a cartilage graft inside. And this would widen this is the graft getting in place, and it would need to be secured between the two cut ends. This is a part of a rib graft, usually take about 1 centimeter or so. And once it is secured in its place, like a button in here, then it widens the posterior part of the glottis, and it can be useful in pediatric cases because it's a non-destructive technique. This is the graft being placed between the two cut ends of the cricoid plate and secured in place, and this has widened the posterior glottis significantly. This would clear the airway, but again they're at a risk of some aspiration and some voice problems as well. The risks and complications for the bilateral vocal fold palsy methods of treatment. Most techniques have comparable results in terms of decannulations and complications. Complications are usually the formation of laryngeal granulomas over raw surface in laser surgery, for example, or posterior glottic stenosis following the organization of these granulomas, or aspiration if you use the more radical procedures, particularly total arytenoidectomy. These are the three most common surgical complications. Revision surgery rates for all types of treatment for bilateral vocal fold palsy is quite high, approaching about 30%. 1 in 3 patients may require another procedure. The pediatric cases usually have a high spontaneous recovery rate, particularly in the idiopathic and the birth trauma cases. About 2/3 of them may recover spontaneously, so it's worth waiting for a year before considering intervention, surgical intervention. Patients who were dependent on tracheostomy can get decannulation in a range of between 50-something and 70-something% of the cases. More than 20% of the cases would require some form of intervention in order to have successful decannulation, and this is usually either a suture, lateralization, or endoscopic cricoid split. The voice and swallowing outcomes are variable. The more you clear the airway, the more risk of aspiration or a weaker, breathier voice. The more radical and surgical intervention would increase that risk substantially. The future direction would be with the emerging therapies, including laryngeal pacing with gene therapy or selective reinnervation, but that would need time before it is established. Local application of MITOMYCIN-C is increasingly being tried with these types of operation. It's a chemotherapeutic agent that can be used to modify wound healing and inhibit post-surgical scar formation. The concentration is about 1 milligram per milliliter, applied topically for about 3 minutes. There is a lack of clear evidence for improvement in the outcomes using mitomycin, but despite this, it's being increasingly employed in these types of surgery. It's important to note that even if the airway is severely compromised, when there is a potential for spontaneous recovery and regeneration of the innervation to the larynx, temporary tracheostomy may be considered, or vocal fold suture lateralization, because these procedures are reversible and non-destructive. Various reinnervation operations have been described. The most promising of them is suturing the accessory phrenic nerve to the posterior cricoarytenoid muscle, and this would provide a dynamic opening of the glottis during inspiration. The other promising technique would be the implantable electrical stimulation device for laryngeal pacing. Open surgical augmentation procedures for the larynx may be considered for the failed endoscopic approaches after trying posterior cordotomy or arytenoid, lasing the arytenoid, or even posterior cricoid split. These techniques may be considered, particularly with extensive stenosis or in cases with congenital problems and severe airway compromise. There are several of these augmentation techniques. You may try augmenting the anterior or posterior parts of the airway after a laryngeal fissure, or after a cricoid split anteriorly or a cricoid split posteriorly, and using cartilage grafts to augment the diameter of the airway. This has been tried more in children, and sometimes a major framework for the larynx have also been tried in severe cases of extensive stenosis or revision after several operations. Sometimes the answer is a long-term tracheostomy. It's still indicated in patients who refuse other more extensive procedures after failure of the endoscopic approaches, or in high-risk patients. It's a very effective way of providing an airway and keeping good voice and swallowing functions. There is a small addition to the procedure of selective muscle reinnervation when the accessory phrenic nerve is used to stimulate the paralyzed abductors, the posterior cricoarytenoid. This has been reported to produce promising decannulation rate and improved airway function. Botox injection into the adductors would provide transient airway improvement in these cases. Sometimes there is still some tone or some residual activity in the adductors as well. So in addition to this selective muscle reinnervation procedure, Botox injection into the adductors has some benefit. It's being increasingly utilized in the pediatric cases. So in conclusion, the difficulty in the management of bilateral vocal fold palsy comes from the balancing act between securing an airway or preserving voice and swallowing. This is a very delicate balance, and no single strategy can be applied universally, but the management must be individualized. It's important to differentiate between paralysis and fixation of the cricoarytenoid joint, because the prognosis and the management plans would differ substantially. In the acute settings, tracheostomy remains the workhorse, Other alternatives are the suture lateralization, or even sometimes posterior cordotomy, the microsurgical techniques using laser, either posterior cordotomy or partial arytenoidectomy. The other techniques of reinnervation, these can provide a dynamic restoration of the airway, and also laryngeal pacing holds a good promise for improvement in the future. The expectant management of potential recovery with conservative airway support and using only reversible interventions like a temporary tracheostomy or a suture lateralization is required in cases in whom the spontaneous recovery may be expected. By this, we come to the end of this presentation on bilateral vocal fold palsy. Assalamu alaikum.